Background medical therapy in heart failure has really rapidly evolved in recent years with the introduction of new therapeutic classes. And um, across biomedicine, this is probably an area that has had the greatest growth in terms of available therapies. And now guidelines are really strongly recommending the combined use of these medicines, especially in heart failure with reduced ejection fraction, the use of four pillars used early in the disease process in combination and continued over the life course of a patient's to reduce the risk of hospitalizations and mortality. SGLT2 inhibitors are the last of those pillars that was recently added in recent years, and it's a very nice drug class in the sense that it's relatively easy to use. It's a fixed dose in heart failure, doesn't require titration, is generally well tolerated, and has minimal side effects, minimal effects on blood pressure, kidney function, electrolytes. And so for all those reasons, the implementation of SGLT2 inhibitors has actually even been somewhat easier than other prior drug classes in heart failure, and can easily be combined with other foundational drug classes. So in that sense, the SGLT2 inhibitors have actually been a remarkable success and a remarkable addition to the armamentarium of available therapies in heart failure. Compared with prior drug classes where we had multiple doses, where we often would start with a low dose, ensure tolerability, then bring the patient back, may titrate the dose upwards. We may need to, in prior drug classes like the mineralocorticoid receptor antagonists, we really were concerned about side effects such as hyperkalemia, and so we needed to bring the patient back for early laboratory monitoring. With certain prior drug classes like the angiotensin receptor neprilysin inhibitor, sacubitril/valsartan, we were concerned about blood pressure effects, and sometimes patients didn't tolerate it because of undue blood pressure lowering or hypotension. All those issues are not major concerns with the SGLT2 inhibitors. They can be started with limited monitoring, and we can feel reassured as clinicians that these therapies will be safe when used, and so patients like them. The other aspect that makes it much easier is that there's some ground level familiarity amongst clinicians because these therapies are not new to biomedicine. They are been introduced initially as diabetes therapies. They've been available for chronic kidney disease management, and also now for heart failure. And so because of that, not just cardiologists, but also general practitioners, endocrinologists, nephrologists are all jointly involved in the prescription management of SGLT2 inhibitors in these patients.